Okay. Also, first order of business is a roll call.
Senator Beitman. Senator Brennan. Senator Rothfuss. Senator Steinmetz. Representative Allred. Representative Andrew. Representative Berger.
Here.
Representative Brown. Representative Clausen.
Here.
Representative Lawley. Representative Obermueller. Representative Provenza. Co-chairman Northrup.
Here.
Co-chairman Scott.
Here.
You have a quorum.
Okay. First thing we're going to do is hold over from yesterday. In the public comment at the end of the meeting, there was a suggestion for a bill. Representative Berger, do you want to refresh our memory as to what that was all about?
Yeah, Mr. Chairman, thank you. So Lindsay Adams talked about a bill, and we've been talking a little bit with a few of us here on this committee, just drafting a bill that would essentially have kids that do graduate from Wyoming high schools be able to access our colleges and pay in-state tuition. So we're just looking at a draft bill idea. I mean, I'm thinking the kid would have to at least be in, not a lot of those kids, she said, are here in elementary school. A lot of those kids come in elementary, they use our schools, and then also maybe a kid that at least go through our high school system to be able to qualify for that. So just looking at an idea and drafting that bill.
Potential implications in this one both ways. It's potentially a way to build the enrollment and get some pretty high-class students at the university, community colleges, but it will have a potential cost to it. I don't know how great it is because I think we're just not getting them right now. So committee, it's arguably within our charge on the community college issue. What we want to do is get a bill draft, get it circulated, and and what I'm going to ask Chairman Northrup is that the members talk to their committee chairman, and then we'll make a decision. And we're going to put it on the agenda for the next meeting potentially, or not.
That sounds like a good idea.
So that's something we're going to think about. Is that an issue we want to get into as a committee, or is this a private bill? So the first step will be to get a bill draft and LSO. We do ask you to work with Representative Berger and get us a bill draft. And then as soon as he's okay with it, get it circulated to the committee so members can take a look at it. Okay?
Thank you, Mr. Chairman. I
There may
appreciate
not
that.
wind up on
Yeah,
the
absolutely. I just wanted to see the idea on the bill and just see what everyone
You'll
thought.
have to think
Okay.
about how long, do they have to just
Absolutely.
graduate? Do they have to have attended for so
Yep,
many
there's a lot
years?
to it.
Some issues in there. And you'll have to think about the fiscal implications. You might want to talk to Senator Rothfuss because he knows a good deal about the university. If their students we're just not getting,
Perfect.
and we're just adding students, then you got to look at, is that a marginal cost for us?
Yep.
And you might want to talk to the Community College Commission on the same thing.
Correct. Thank you, Mr. Chairman.
Mr. Chairman,
And if I-
shouldn't we be voting on it now before we go into this exercise? And if there's not interest in the committee to pursue it, wouldn't we just be using up LSO's time?
We would prefer to have something a little more specific to look at before we vote. And so we want to get that done, and then we can, frankly, I want to take an informal poll to see is it something we want to pursue? And should we put it on, and the question in parts, should we put it on the agenda to look at? It may well wind up being a private bill. But we don't know enough to make an intelligent decision at this point, so.
Okay, so is it a fair game for all of us to do this as well? Just throw bills out there that,
Yeah, that are related. The first question was it within our charge, and it appears to be.
okay?
Okay? With that, the next item on the agenda is the mental health services. And we've got a number of people listed to talk to us. Do we want to hear from them all at once, or do they want to appear separately? We've got Stefan Johansson here. I thought I saw him earlier. Yes. If the health department will lead off on this, and then we'll go to the education department.
Mr. Chairman, they did submit a joint presentation.
Okay.
So they'll be all together.
They'll be all together. Okay.
Mr. Chairman, members of the committee, Stefan Johansson, Director for the Wyoming Department of Health. I'm going to leverage my colleague sitting to my right with Lee Grossman, who is our state Medicaid agent and Senior Administrator of the Healthcare Financing Division, and Sarah Rogers, who also works in the Healthcare Financing Division. As I mentioned earlier this morning during our informal breakfast, there's a lot of behavioral health work that has gone on in the Department of Health. But what we were asked to present on is really more related, as we were discussing, to the school-based services program that was recently legislated and implemented. And I'll have Mr. Grossman and Ms. Rogers give you a brief overview and answer any questions you might have there. But it's worth mentioning, Mr. Chairman, as we were discussing this morning, going back to Senate File 60 from, I believe, 2013, a lot of Medicaid reform and changes have happened in the behavioral health world. Going back the last 10 years, our developmental disability waivers have been redesigned. As I mentioned, we've reconstructed our state hospital and our Wyoming Life Resource Center, and we're in the process of implementing the community behavioral health redesign that you all legislated 2 sessions ago. So a lot of, I think, positive developments have happened in this space. But again, our presentation this morning in conjunction with our other agencies is most related to Medicaid school-based services for our adolescents in the K through 12 system. And with that, with your permission, Mr. Chairman, I'll hand it over to Mr. Grossman and get out of the way so I think some other agency folks can occupy my seat. Mr. Chairman, absolutely.
Good morning, Mr. Chairman, members of the committee. I'm actually going to turn it over to my colleague first from the Department of Education, and then we'll get into the Medicaid space.
Good morning, Mr. Chairman. Laurel Ballard from the Department of Education. I am the Innovations Officer for the Department of Education. With me, I have Dustin Brown, who is our Director for the Project Aware work that we've been doing. And he and I will both be kind of covering the different things that we've been working on in mental health care in our K-12 setting. I will say we've got today, just so you know, we do have quite a few of us that'll be talking. So the department will be talking about the work that we've been doing through our tiered supports for school districts around mental health. Then we'll turn it over to the Department of Health to talk about Medicaid. Then Family Services is going to talk about the population needs and access, and then the rehab division, vocational rehabilitation division from the Department of Workforce Services will kind of close us out for today. So, Mr. Chairman, the first thing I want to do is kind of take a second and kind of talk about why this is important, why the Department of Education has been jumping in and working on this. We've done a lot of work on this since 2020 to kind of think about what kind of supports that we need to put into school districts. But I want to kind of highlight two of these data points for you. The first one is the fact that Wyoming has the highest prevalence rate of youth-based major depressive episodes in the US. It's an issue across the country, but it is an absolute issue in Wyoming. Through our prevention needs assessment, we know that 9% of our students, almost 1 in 10, right? Students have attempted suicide in the last 12 months. It's not even suicidal ideation. Those are students that have actually taken action in attempting suicide. I know this one's hard to read, so I apologize. It is in your book, but I will kind of go through it. So as we think about this, we think about a multi-tiered system of support. That's what MTSS stands for. And thinking about that in terms of mental wellness and behavior. We have done a lot of work, and school districts have done a lot of work in thinking about the multi-tiered systems of support around academics. So if I have a student that is struggling, we have supports and interventions in place, right, in terms of teaching reading. As students struggle, right, we provide additional supports for them, right, for those that need additional supports. And then if you think about something like students that need special education services, that's like that tier 1. So if
Interrupt you at this point. The diagram in the book I found to be unreadable. I could not read it last night. So I'm going to, and I don't know whether others had that same trouble or not, but go, as you present, go into some detail on what you're talking about, this tiered system, because the thing that was furnished just didn't work.
Mr. Chairman, I appreciate the feedback, and we will absolutely go into quite some detail then. So as we think about the mental health services and how we provide supports for students with mental health and behavior, the tier 1 is the kinds of things that you do for all students. We call it the universal tier, right? So if you want to think about what this looks like, it is designed for all students, no matter whether or not they're at risk of suicide or have mental behavior or mental health needs. If you want to think about the kinds of things that are in here, it's like doing things like substance abuse awareness. It would include violence and prevention, bullying prevention, even clear classroom expectations, professional development for all staff, making sure you have communication with all parents about things that are going on. And so these are just kind of things that we do, that we provide for all students. When you go to tier 2, we call that the targeted support level, right? It's selective. When you're thinking about these kids that are in this tier, we're talking about 15% of the population or so. So when you start talking about these guys, these are students that have an identified risk of suicide or substance abuse. They have a recognized history of trauma. They have a recognized mental or behavioral health need as we go through this. And so then you start thinking about, so what do we do for these students? So this is where you can do things like mentoring, provide like big brothers, big sisters for some of these kids, or doing group counseling sessions, targeted parent and caregiver communication and training would happen in here. When we get to tier 3, these are the students that need intensive supports. They're designed for students that are highly at risk of suicide or substance abuse. They may have already attempted suicide and are exhibiting concerning behaviors due to the complex mental and behavioral health issues. You'll find students in here that are on individual education plans, so the IEPs. And here we tend to do things like non-crisis interventions, thinking about safety planning interventions, individual therapy for students. And at this point, we have extensive and targeted communication with those parents and caregivers. Oops, wrong way.
This important concept.
Thank you, Mr. Chairman. I'm looking at the slide before where you had some facts and figures. some statistics, but I don't see any citations. I was just wondering where you got the data so I can look at the data.
Mr. Chairman, the data came from the state school mental health report. It's a federal report that's populated every 2 years. I'd be happy to send that forward.
Okay, thanks.
It's strongly, Mr. Chairman, it's strongly reliable. Mr. Chairman, they use various data sources. They use claim and billing data across the federal government. They utilize other reportables for things like access to care. They utilize diagnostic criteria across all the states collectively to formulate those rankings and those objective measures that they place in there.
How do you all identify students that you're putting in your tier 2 and tier 1?
Mr. Chairman, the primary method of referral is either referral from a source within the school district, like a school counselor, a teacher, an administrative member. That's the primary referral source, or the family themselves. We've got a very strong familial referral process. If, say, a parent recognizes a need with their child, then that's a direct referral that doesn't necessarily facilitate. Depending on the district, there could be interventions where we do screenings and things like that. But predominantly, if a parent refers, we bring them into our programs.
Mr. Chairman, we've recently been working on, I believe Superintendent Degenfelder talked about this a little bit, about creating a mental and emotional well-being framework for our K-12 schools. We call it the Thrive Framework, based off of the competencies and the things we would like, the knowledge, the skills, the mindsets that we are hoping students will be able to develop. So it's kind of built in, the two pieces. One piece is the competencies that students need to know and do. So the kinds of things we have include something like thinking through decisions, which, if we're talking about what that really means, it means the ability to make informed choices and engage in problem solving. The second one is talking about respect for others. So it's the ability to recognize others' perspectives or ideas and experiences to support and facilitate an environment of trust. When we're talking about inspiring action, it's the ability to become internally motivated to drive your actions that influence oneself, others, and the community in positive and helpful ways. Value relationships is about the ability to develop and maintain relationships within personal, family, school, work, and community settings. And then the last one is elevating oneself, which is really the ability to understand yourself and prioritize self-care and personal growth. And while we have these and we have these set up for students, it really rests on this foundation that we call the conditions for success. So we think about the conditions of success. We've identified 5 areas of need that need to be in place in order for students to be able to really develop some of these competencies. So the first one is looking at mental health and well-being for adults. So in this, we're talking about the abilities of adults to strive and maintain a healthy balance between work and personal life, knowing that it can be different for each person. We're talking about adults working together to strengthen their sense of connectedness with each other, both within the school and within the community. We're talking about adults being able to find value in their roles within their family, school, and community. The second one we've identified is learning and collaboration for adults. In this case, we're talking about adults engaging in collaboration, professional learning, and feedback cycles on mental and emotional well-being at multiple tiers as it aligns to their roles within the schools. It's talking about adults developing the mindsets that are needed to support mental and emotional well-being. So if we think about that, this idea of growth mindsets, personal and collective efficacy, and maintaining and ensuring we have high expectations for all students. It's also talking about adults implementing strategies to support their own mental and emotional well-being. At the core of this, we think is, and reasons why it's in the center, is that we believe that parent, family, and community engagement is absolutely critical. So parents and families, schools, and the community need to share ownership and responsibility for student growth. It means that we have meaningful, ongoing, mutual communication, creating respectful and trusting relationships that are developed between schools, parents, families, and the community. And we're also talking about the ability for parents, families, schools, and the community to collaborate to provide pathways to be able to share and outsource resources and supports in a non-judgmental space. In the next one, we have the tiered systematic processes to support students in mental emotional well-being. That's that MTSS. It's important that you have these tiered services and supports in place. So in this place, then you're actually looking at then making sure you have a continuous improvement process in place to ensure that there's ongoing effectiveness, that a team structure includes expertise in mental and emotional well-being to contribute to the decision-making versus just having folks that are focused on the academics. And then we are also talking about then partnerships with families and caregivers that are developed to honor the individual needs of students. The last one is the positive climate and culture. In this case, we're talking about schools and families, caregivers, creating shared and clear expectations for supporting a positive school climate and culture. Schools and families and caregivers are engaging in transparent and collaborative communication that allows for ongoing input and feedback to build trusting relationships. And the school climate and culture inspires a sense of belonging for all students, staff, families, and caregivers. So, Mr. Chairman, we have put together this framework using an advisory panel from across the state. We have had, it's at least 20 people on our advisory committee, ranging from superintendents, teachers, counselors. We have had community representation, right, from mental health providers in the community. Lots of folks that help build the framework itself. We also have as we built this, we did focus groups across the state. Everybody that I can imagine invited, and lots of people participating, from school board members down to students, from parents and families, and interested folks that are in the communities, healthcare providers that help provide kind of the guidance as to what goes into this. So right now we are in the process of getting ready to pilot this. We closed applications for the pilot last week, and we are in the process of selecting 6 schools, or sites is really what we're calling them, to be able to pilot it so that it can be a single school in a district to having an entire school district that may want to pilot this work. This is not designed to replace things that districts are already doing. It's really designed to be something that helps support districts to make sure they have all the pieces in place to know how it all fits together. And so it's intended to provide support to districts in being able and doing that. And then so the piloting is really about figuring out what that really looks like, developing the best practices and the lessons learned that we think about implementation of a framework like this. As we go through this, we are also providing districts with the idea of the developmental indicators for the student competencies. Obviously, these are pretty broad categories of things that we want students to know. So we have broken it down into developmental indicators that kind of help a K-2 teacher think about, what does this look like for our early elementary students? What does it look like for our 3-5 students? What does it look like in middle school? What does it look like in high school? They're designed to be aligned so you can kind of see how 3-5 builds on K-2, which then builds, creates the foundation for 6-8, which then builds the foundation, right, for the 9-12, so that we're building skills over time for the students. We're working on, and we've created an implementation guide that we'll be working with districts on that kind of thinks about these conditions for success and thinking about how you implement it. We spend a lot of time talking about in there about, for all these different conditions, how do all the different roles that interact with schools, right? So how do school counselors and district administrators, school administrators, families, students, out-of-school providers, right? Like our after-school providers, how do they all fit together to be able to solve some of the issues that are connected with these different conditions? We're also creating tools and supports for districts that help with effectively implementing the framework. And we're creating professional development so that once we're outside of the pilot, we have resources for schools and districts that are interested in implementing the framework to be able to have supports and resources that may not exist otherwise outside the pilot. Mr. Chairman, I'm going to turn it over here to Mr. Brown to talk about think a little bit more about the mental health in schools and kind of thinking more about like the tier 2, tier 3 level of services.
Thank you, Dr. Ballard. Mr. Chairman, when we look at school-based mental health, we largely look at it from two approaches. We have the left, the advantages of hiring versus the advantages of partnerships on the right. And what this looks like is some of the constructs and some of the ideas that we've had over the last couple of years within the state. The advantages of hiring are maintaining within that closed loop of the school district, providing additional school counselors within the school setting to serve some of those immediate needs. Doing things like providing resources directly to the school districts to meet mental health and substance abuse needs. What we do with Wyoming Project Aware is actually aligned with the right side of this chart, the advantages of partnerships. What we do is we recognize that all the resources cannot be found within the school district. What it takes is and requires is a partnership between our school districts and our behavioral health organizations within our community. What we do is over the last 3.5 years, we've worked to create partnerships between our school districts and our behavioral health organizations within the state. We actually have two models. We have one which is an in-person model, and we have one model which is a telehealth model. The telehealth model currently is utilizing behavioral health organizations within the state, but for example, they may be located here in Casper, Wyoming, and serving individuals in Uinta County School District number 1, for example. That's a very tangible idea of what we're doing with our partnerships with Wyoming Project Aware. Now, what we do is we start our process off through consent. We require consent from a familial process. So the parent caregiver and the student have to be in agreement that these services are appropriate for their family unit. And so what we do once we have that agreement between them, we enter them into services. We target a 28-day goal of receiving services once we have that consent on file. What we found is whenever we've gone into these districts in some instances, district, county, different ways that you can look at it, the availability of appointments could be 3 months, 4 months, 5 months out. A lot of these communities don't have the capability to see, for example, a student with anxiety because the resources are actually going to crisis intervention. Students that are advanced in suicidal ideation, homicidal ideation, self-harm, those things tend to bump students that are needing to be seen for anxiety or depression because those are more urgent or emergent needs within our community. Next slide, please. So our project, Project Aware, is actually 5 different projects. We started with one grant in 2020 with Campbell County, Fremont County, and Park County. Our success there led to a second project. Our second project was our first telehealth project. Then we moved into our mental health and positive choices program. This is a cohort model that's operating out of Bighorn County. It's Bighorn County 1, 2, 3, and also Park County 16. We also received a Wyoming Trauma-Informed Services grant in 2022. And then lastly, internally, we've been able to work an additional project, which we're calling the Mental Health and Substance Abuse Treatment Grants, which that is running currently, and it will expire December 30th, 2024. The big thing to note here is these are all grant funded. The sustainability piece, we're working with our proof of concept, but all of these will sunset. All of these funding sources will sunset with the federal government or with state resources that we've currently dedicated to this. Right now, we're serving approximately a third of our student population. And whenever I say we're serving a third of our student population, we have coverage for a third of our student population, but we specifically target 4% of individuals to receive our Tier 3 clinical intervention services. So we have approximately 4% of the students in these districts that are receiving counseling, receiving substance abuse services, receiving group counseling sessions, family counseling sessions. Family counseling is all part of our program. And then on our graphic, you'll also see the partnering organizations that we have within the state. These partners understand the need and the desirability of bringing services to where students are, and that's the school setting. All of our districts provide transportation or transportation in conjunction with the school district to take the students to receive those counseling services. In our telehealth model, for the most part, we have a telehealth room equipped in each of our schools, and the student will leave their class, go to their counseling session, take the time they need to adjust back to coming into class, and then they'll return back to the school day. So there's minimal impact on our student population from an education perspective. How we've really designed this program is, we use an analogy that if a student is hungry sitting in their seat, they're not focused on differential equations. They're not focused on literature reviews and writing research papers. They're focused on being hungry. The same is true with anxiety and depression. If a student or child is spiraling with anxiety or depression, they're likely not focused on differential equations. They're not focused on research papers. I would say 90% of what we see in our program is anxiety and depression. When we look at our top 5 diagnoses, anxiety is number 1, depression is number 2, PTSD is number 3, and operational defiant order is number 4. Depression is actually categorized twice in 2 different ways, major depressive episodes, and then essentially an unspecified other. So we have depression reflected twice in our top 5 diagnosis, if that makes sense.
Thank you, Mr. Chairman. Can you walk me through what it would look like? You have a student, junior in high school, they're sitting in class and they're feeling anxious and depressed. You kind of laid out a few different requirements and timelines and signatures and everything that has to kind of effectively take place. And this is a student that's currently anxious and potentially depressed, may or may not be looking for support, and honestly may or may not be comfortable with counselors in school or their teacher or anything along those lines. What has to transpire before that student is either face-to-face virtually or face-to-face actually in person with a mental health provider? What are the steps and what's the timeline?
Yeah, Mr. Chairman, Senator, the timeline starts with the consent process. So our district, we give 3 opportunities for consent. We look at a 7 to 10 day window to request that paperwork back from the parents and the parents or caregiver.
No, be the student at this point in time.
Yes.
What takes place as the student? Because there's a whole process that's going to take place even before I assume the consent is taking place. So what's that student's look into this situation?
Yeah, Mr. Chairman, Senator, the student has to be recognized as need. Either that recognition could be self-recognition or it could be the teacher recognizing that need. That initiates the consent process. Once we have the consent process, we move into scheduling for the appointment. We have a mental health aide which functions as a case manager for this. That mental health aide sees, do they need food, do they need housing assistance, those kind of things, along with scheduling the appointment. That appointment is scheduled we target within 28 days. Of that, where we have them in a seat with a counselor, either through telehealth or through the in-person process. Once that initial visit occurs, we set up a care plan, and that care plan essentially walks through what that episode of care, the treatment for that episode of care looks like. So, if I'm a student sitting with anxiety, how do we meet the immediate needs of anxiety? And then how do we create maintenance structures? How do we create coping mechanisms and things like that for the student? And then we progress through the episode of care. And the average length of time in our program is 5 months. So you would anticipate weekly or biweekly counseling for 5 months approximately for the student to develop the skills and the tools necessary to work with that anxiety that they have internally. Did I answer your question, Senator?
Yeah, you did. Thank you. A quick follow-up is, and it sounds like there's some interim services in most locations prior to that first 28 days, and would those require a consent process to take place prior to that?
Mr. Chairman, Senator, yes. The mental health aide will not initiate contact with the student until the consent process has been completed. So we would look at our program. You know, I've talked about it before, that we look at the physical health of the student, the mental health of the student, and the spiritual health of the student. So those resources can be provided in conjunction with the familial unit in what is actually needed for that familial unit, or if it's not needed for the familial unit, for that student specifically.
And Mr. Chairman, final question, is there any discussion about a pre-consent process, an initial waiver, something along those lines? Because it does seem like there's an understandably necessary step, but a step that might be the kind of thing that could be taken care of earlier if there was, you know, as you're going into the school year or something like that, there's plenty of paperwork filled out. That might be the kind of form that could be filled out. It wouldn't have to be filled out, certainly not compulsory. Has that been discussed?
Mr. Chairman, Senator, we haven't discussed that in our construct, but it is really something worth considering. So I thank you for that,
Okay.
that idea.
Thank you.
Mr. Chairman, I think we have one more slide to talk through.
Let's do that.
Mr. Chairman, our final slide. What we've done, we started direct care service in February 21. In that time, we've served 1,400 students. That is just direct care clinical tier 3 services. So this is one-on-one individual counseling, one-on-one substance abuse, those type of services. We've also trained 1,300 personnel each year in things like youth mental health first aid. We've built capacity, we've built sustainability within our program from these teaching opportunities. All of our services come at no cost to families. All of our grants were written to cover copays. We treat underinsured as if they were uninsured students, because the reality is if you have a $1,500 deductible until your healthcare plan kicks in, truly for many families, those services aren't affordable. So we treat our underinsured as if they were uninsured. Now, going back to where we fall with youth access, in 2020, Wyoming ranked 44th in youth access to mental health services. Now in 22, we rank 36th in youth access to services. So, you know, Project Aware is not the only effort going into this. We've got a room full of individuals here that are all focused in this space. But things, when we focus our attention in there, we're seeing some success in bringing access forward. So thank you for this opportunity to let me present to you today.
Thank you, Mr. Chairman. I guess my question would be is how do we measure success? So when I was looking up your Project Aware, it looks like it started in 2014. So we're coming up on 10 years of the program. And it sounds like we're still 1 out of 10 students, that's serious. As far as a suicidal tendency or mental health problem. I'm not sure which you were actually referring to. However, sometimes, and this is a serious problem and we all take it seriously and we're all concerned about it. So I'll preface my remarks before that. But I guess sometimes I see us chasing grants and federal money and all of those things. And my question then is it working? And are those things actually working for us, or do we need to back up, reevaluate, and really say, is what we're doing working? One, how do we measure success? And then two, do we need to relook at this through a different lens rather than what federal grants are available? Thank you. If you could answer that.
Mr. Chairman, Senator, while Project Aware started in 2014, the first Wyoming grant was issued in 2020, at the end of 2020, actually, October 1st, 2020. So our participation as a state has really only been these last 3 years. Now, when we talk about measuring success and outcomes, we don't have enough data to declare statistical significance. We do have anecdotal data where, for instance, we had 3 individuals that have attempted suicide and reported that as part of our program, and there's been no relapses with those individuals into suicidal ideation, homicidal ideation. Now that's, again, 3 students is too small of a number to declare statistical significance, but we are seeing, when we measure knowledge, attitudes, and beliefs about mental health and substance abuse services within our communities that we're working in, we are seeing trends in positive directions. We're seeing greater capability to identify student need. We're seeing greater capability to bring students into the program and receive successful counseling services. And then we're showing good clinical success when we talk about episodes of care. Our length of time in the program is on par with federal, I guess not federal, but accepted standards of care and timelines associated with how long it treats to treat an episode of anxiety or an episode of depression. The last point about federal grants, I think you really hit the nail on the head here. All of our grants are going to sunset. So the question becomes, do we continue to go after federal grants and sustain and maintain our projects through federal grants? Knowing that, the more plates we put in the air to juggle, the more likely that one of them is going to fall. Really a sustainable funding source would help our work. Our telehealth construct is 70% sustainable in and of itself. Which is where we do think there's more efficiency and effectiveness that can be made there. Our in-person model is currently 56% sustainable. Thank you, Senator.
Thank you, Mr. Chairman. So just kind of back up and maybe go into a little bit more depth on, as you just mentioned, specifically Project Aware, right? As I look at your slide, we've got this till 2025 is the grant period. So we've got another 2.5 years-ish or 1.5 years-ish, and then it's going to sunset. So we're looking at roughly $2 million a year. Has there already been discussions as to what that looks like, number one, if this just does sunset, number one? And then number two would be, is there a cost share, right? So I think some of my Senate colleagues have asked this question multiple times of what are the strings attached to this federal funding? But if there's a cost share, what is the state putting forward to match this $1.8 million that's coming in? My understanding, this was ARPA, I believe, if I remember correctly, but I'm just kind of curious, if there is a cost share, what does that look like? What are the strings attached to that? Because to me, we see success, right? At the last slide that you just had up there was we went from 44th in use access to mental health care to now 36. That in itself is a level of success. Maybe not what everybody wants to see success, but some things are not objectively measured. So if you could answer those two questions, I'd appreciate it.
Absolutely. Mr. Chairman, Representative, the grants here are actually no cost. The grants here are no cost share. Now, the AWARE grants themselves require the data to be reported back to the federal government. So what we do is we have about 20 minutes of data collection with the first appointment for each student, and that gets reported back. And what they're looking for is they're looking for national trends in students, increase in prevalence need, increase in suicidal ideation, homicidal ideation. What they're trying to see is mental health worsening within the country with a lot of that data. Now, on the On the other side, I'm working with our behavioral health partners to determine when the grant funding ends, are they going to remain in our districts? And where we are when I talk about sustainability, our telehealth construct produces 85,000 a year in sustainability. Our construct requires 120,000 based on today's current salaries to maintain, to break even essentially. And so the question becomes, do we have a funding opportunity that gets us to that other piece? Can we create additional efficiencies and effectiveness to get there? I just anecdotally, I think, because whenever I say my sustainability, it's without external funding streams that I don't have access to, private insurance payer data and things like that I won't have access to. There could be additional sustainability that our behavioral health partners recognize that I can't recognize on my side. So I think the sustainability is a little bit, there's more to it than that. Representative, did I answer your questions? I'm sorry, Mr. Chairman.
It's a, yeah, you're talking about ability to sustain what you're doing in the remote part of this long-term without the federal grants? Is that what you're talking about? I'm confused.
Mr. Chairman, yes, that's what I'm referencing. So right now, our grants support hiring the providers, the mental health aides. We have community project managers, which create the liaison between the school district and the behavioral health partner. The schools and mental health practitioners fundamentally speak different languages. So we need an intermediary that can start creating common terminology that can work through communication issues. So this is what our grant does. Our grant brings all these pieces together. Now, when I talk about sustainability, when the federal funds sunset, I think we're approximately 70% sustainable where we are right now. So we're looking for additional sustainability.
Okay, so you're talking about how much additional funding we're going to need to keep this project going.
Yes,
once
Mr.
those
Chairman.
grants terminate. That's what you're talking about. Okay. Representative.
Thank you, Mr. Chairman. This is before my time, so I might be incorrect in my understanding of it, but I believe the state of Wyoming stopped using the youth risk assessment survey. I don't remember what year that was, but essentially I'm wondering if that would have been a way to maybe measure impact of programs like this across the state of Wyoming in terms of, can we then say we've seen this decrease in this risky behavior or other measures other than suicide outcomes, right? So I'm curious if that's something that's been difficult for you in terms of being able to say, this is how we know that we're successful in our work from an aggregate standpoint, rather than that anecdotal evidence.
Mr. Chairman, Representative, having that survey back would be beneficial. Right now, our primary method is the PNA, and it's not as comprehensive as that survey was. So yeah, a lot of our data we measure with what we have local access to, whether that's through the PNA. We also have surveys that we've incorporated into the districts we're working with, and also our NOMS data, which NOMS is our national outcome measures. This is the data that I referenced earlier that gets reported back to the federal government. That is how we're making decisions currently in the process. More data is always going to be helpful in making better decisions.
Thank you, Mr. Chair. Just a question on the mental health aides. Where are they located? Is this a school level, district, state level? And then are these people with extra training or is this their whole job?
Mr. Chairman, Representative, That's a great question. So our mental health aides actually work within the districts where we're providing services. For example, where we're delivering telehealth services out of Casper, but we're in Uinta County School District number 1, that mental health aide lives and serves in the Uinta County School District number 1. This is their primary job. They help support getting students, particularly our younger, like our R1, our second graders. They help support them in the telehealth, because if you put a kindergartner in a room, they're probably going to wander off screen. They're going to do things that is just natural and normal for a kindergartner to do. So the mental health aide will help facilitate that telehealth visit. And they also provide all those wraparound services. So access to food pantries, access to homeless shelters, domestic violence shelters, all of those things that potentially also impact the socioeconomic status of the individual that is receiving services.
Representative Overview next.
Thank you, Mr. Chairman. In your discussion about assessment of the kids at risk, you were talking about different components of that assessment, including an assessment of their spiritual well-being. I believe you referenced that. Can you talk to us about how you think about that component, what you observe about that component in the populations, and follow up with maybe how you see the robustness, I guess, of those kinds of services in your partnership group? Thank you.
Mr. Chairman, Representative, so my direct data is limited on that. We don't report back the wraparound services that are being utilized with the mental health aid. And some of this originates with my background. I'm a retired U.S. Air Force captain, and a big thing in the military is recognizing that physical health, mental health, and spiritual health make up the components of an individual. So that is something that we've built into the mental health aide's position description, that they can use their case management abilities to provide the individual student level needs that are there. And so, spiritual needs would account for that based on the individual, but I couldn't speak to a percentage of, students that we're supporting in that area.
Thank you. Okay. Cindy?
Thank you, Mr. Chairman. I want to have you help me clear up some confusion factually. Senator Steinmetz mentioned that the Project Aware was created back in around 2014. But am I correct about this particular service approach, a service implementation, wraparound services, really didn't begin to, you say on that slide, February 1st, 2021, is that correct?
Mr. Chairman, Representative, yes, that's correct. So the federal program began in 2014, but our first grant was awarded October 1st, 2020. And then correspondingly, we started seeing students on February 1st, 21.
So the implementation of this program we're talking about, the wraparound services, coordinating of those through mental health aides, has just begun in February 2021, and the measures you've given are of that short period of time. Is that
correct,
accurate?
Representative?
Okay, thank you.
Okay, Senator Brightman.
Thank you, Mr. Chairman. My question for the WDE is, I don't know if I'm listening to the Department of Education or the Department of Health. To me, this is a very giant leap into uncharted territory for the Department of Education, and a philosophical question we have to ask ourselves: is this too far? Is mental health in schools beyond the scope of the Department of Education? Is it your policy now as a department to get into healthcare issues, and where do you stop? I mean, dental care is a big deal. There's 46, I think there's a stat from the CDC, there was 46 million classroom hours lost due to dental emergencies. Are you going to hire a dentist for every school? Where does it stop? And do you feel like this is a major encroachment upon parental rights as well.
Mr. Chairman, I'll take a stab at it, Senator Beitman. What we're finding is that we have had students that need care and parents aren't able to support the care, like leaving work, taking a student to an appointment, bringing them back to school, going back to work, making time for being able to do things like family counseling. It helps support some of those kinds of things. I don't believe it's taking away from parental rights for kids, because this is not done outside of the parent, right? We don't even, that's, I think, Mr. Brown was talking about, we don't even like meet with the student. There's no, and there may be a referral, and then it goes to the parent to say, are you good with this, right? And so, do you want this? Do you want these services for your students? And so, and then they are just like as if I have my daughter, I take her to an appointment. At that point, I am just as kept in the loop. I am communicated with. So this is not happening outside of the parent and the family. So I would say, no, I don't think so. It's providing an additional set of services and supports that are definitely needed in schools, or definitely needed for students.
Okay, let me take a further stab at that one too. This is not as new as you might think to have a degree of mental health services. When I first started in the legislature, I know that our school district was contracting with the local mental health center here, and the focus mostly was with the junior high kids. There've been a set of problems there, probably since the beginning of time, as certain kids have difficulty at that level of their development. And we started seeing, my late wife worked at the Child Development Center here, so dealing with preschool kids. And right at the end of her career, you started seeing clear mental health problems there, I think reflecting the breakdown of our family system. The troubles we're having there and the troubles with drug abuse have consequences, and the schools have had to deal with them because they've got the kids in front of them. So this is a more complex issue than simply is the school building in a mental health area. We've got some real problems that are affecting the education that are not being dealt with. And in my mind, a good part of it is a symptom of our family breakdown that we're suffering as a society. So I think that's one of the reasons this issue is in front of us. Representative Oromio.
Thank you, Mr. Chairman. I'd like to follow up on that theme also. The argument being projected is that you're swerving out of your lane and into faith-based, church-based, family-based lanes. Do you have any, how do you think about the faith-based lane? Is there an alternative there that you see in the state, that you're competing for a lane that the churches are presently providing services in, or how do you see that piece?
Mr. Chairman, I will say, I don't think we spend a lot of time in that lane in terms of the faith-based piece. I think it's a partnership, and I think that's part of what we were talking about before. It's a partnership with family and community to be able to support these students, right? So I don't see a competition with that. At least that's not the intent behind this program. If a family is, right, this is done in conjunction with family. So if family is seeing that there's a need, but I don't want to address through mental health services. I want to work with my church and my faith-based pieces. They have every ability to say no to us and go down that path. They also have the ability to say, I want this and this, right? And dictate the spiritual piece. We have no say in that, really, in that piece, right? It's just the helping to make sure that where it's brought up and where they want supports, then we'll make sure that there are connections and supports to whatever it is that they're looking, that the families are looking for when we connect to that point.
Thank you. So do you have any observations regarding the faith-based piece as to how robust those services are? Or are you just not aware of what they're doing? Or the argument seems to be that you're crossing over into that lane. I mean, from that side of the argument, they're saying you're interfering with us. We have a church, we take care of these kinds of problems, right? It's family, church, we take care of these problems. Do you have any observation of if that's actually happening and that you're competing in that lane?
Mr. Chairman, I don't believe we're competing in that lane. I believe that the family is right, really the basis of the decision as to what types of supports, what types of services, what types of needs a student may have. And so I believe that while we provide access to services, because that's what we're doing, is providing access to mental health counselors. And if a family wants to take advantage of that, then a family may take advantage of that. If the family is interested in wanting to take advantage and use the services and supports that their faith-based community provides, then to me, that is up to the parent, and the parent can decide to use those. We would never say otherwise. We would never even suggest otherwise, right? I mean, these decisions are, while we provide access, the decisions are really up to the parent as to how they want the supports to be provided for kids. They can say, no, we don't want it here. I don't want it through the mental health services at school. I want to find my own supports through counselors in my community, and I want to handle it that way. They can do that. They can say, we just want nothing. They can say they want to go through their faith-based community and the supports and services we provide there. And so while we provide access to mental health care for students, the ultimate arbitrator and decider of what is happening with that kid is parents and the caregivers.
Okay. And committee, we're taking some extra time here, and we're clearly having trouble grappling with some of these issues and concepts. So I think it is worthwhile taking that time. I want to come back to the slide that's labeled 2 primary methods of providing school-based mental health. You're talking about doing it, hiring in the schools, and really contracting with outside outfits, which would include the community mental health centers, but is broader than that. My perception, the bill failed last year. The committee bill failed in Senate committee. It had, I think, 3 problems, one of which was it overtly discriminated against the large districts. And we worked out a compromise on that, but it still failed. And I think one of the reasons was it was clearly focused on having the schools hire a bunch of mental health people. And I think a number of us had problems with that. The other reason I think was just plain the potential cost of it. And the questions about need we've been talking about. On that slide, I think one of the advantages that's not shown on the contracting side of it, which you've labeled advantages of partnerships, is that if you get a rogue counselor that is causing problems themselves, if you've hired them, it's difficult to deal with if they're a school employee. It's, I think, easier to deal with if you're contracting on the outside. So I would suggest that as an addition to that. And Do I see? Okay, go ahead.
Well, thank you, Mr. Chairman. On that point, that was one of my observations as well, is, again, I think the program is constructed well, but where is some sort of process of administrative appeal or bringing to the attention if there is a situation in an individual district where the program you've set and the requirements are not followed concerning consent, or they feel that they haven't been properly notified? I mean, I think that is really important, that there be some kind of a clear process of a check, a balance, and a way specifically for a parent or guardian or caregiver to come back around and say, this isn't being done according to these rules. And I think that would be very helpful. But I think as it's constructed, I see where you really are trying to focus on the parents as the central decision maker. But things can go awry according to, I mean, I agree with Chairman Scott about that. So that was my feedback, is if there could be a specific way that a family could address that concern through a process, administrative process. So.
Okay. Follow up from Senator Ruffus, and then Representative.
Thank you. I just wanted to follow up on what Representative Lawley is saying, because I do think it's absolutely essential that there is appropriate involvement by the parent. But at the same time, I think it's essential that that other side is represented. I want that blanket waiver of, if my kid needs help, I just want to sign once, right? Kid has problem, help kid. I'm comfortable. And I think a lot of parents, when your kid's injured on the playground, take them by ambulance to the hospital. Don't wait for my waiver. Don't wait for my permission. I want to sign that early on. So it's important that every parent gets to make that choice, but I hope we won't go so heavy on the bureaucratic side to ensure that we've never come close to making a mistake, such that we're sacrificing the interests of those that really fully want to involve education, health, and everyone else in the support of their child in the school system and wherever else they may need that support. Because I do see it sort of as the village approach, where everyone should be hopefully looking out and helping other people. And the more we have that, I think the better off we're all going to be. I don't want to require, oh, well, I'm sorry, Senator Rothfuss, you failed to sign line 11 of the third page of the paperwork, the one for last Tuesday, not the one for this week. And as a result, we're not going to be able to provide any mental health support for your child who came in needing that yesterday, but we've got a 28-day waiting period, unfortunately, because we have policies in place. So there can be a balance here, and I think there can be a good process that reflects both the interests of those that want to be very restrictive and want to preclude these types of services, while simultaneously respecting the interests and wishes of those that want to embrace these types of services. It is the parent's choice, but both sides of that choice should be equally and appropriately represented.
Let me go to the department. Do you want to respond to that? And then I have a comment, and then I go to you.
Mr. Chairman, I think flexibility would be great. It's actually something that I'll look at incorporating into the program as soon as possible. With what we're doing, there's no federal rules or regulations with the program operations and program management that would prevent that. So we'll absolutely have that conversation with our school districts and see if we can do some of that to increase some flexibility and give that a try. On the other piece that we were talking about with the advantages of partnerships, a key advantage to the partnership with external partners is we're leveraging their electronic medical records, we're leveraging their Bill of Rights, we're leveraging the underlying infrastructure that they have as our behavioral and
element at play here. A fair amount of the work you were for it is designed to deal with just that circumstance. And I think that takes, and then you have
where, say, the family has need for domestic violence support, we would take them to those services. This would be an at request of the family to say, I'd like to speak with, you know, a spiritual representative, a pastor, a priest, something along those lines. We would make that connection. On our side, there's no support for one spiritual philosophy over another. There's nothing there. It would just be the request of the family is what we would try to support. Yes.
okay. Committee, we need to move on, get to the Medicaid folks. Do we have anything else burning we need to talk about on this one? I think we've heard a lot of things that are food for thought. And some of these concerns that are being raised, we're going to have to satisfy if we're going to go beyond just the occasional federal grant. Okay. Medicaid.
I got you.
So our purpose for being here today is to talk specifically about Medicaid school-based services. You heard from Director Johansson earlier this morning about some of the broader initiatives and focus of the Department of Health in terms of behavioral health services and how some of that has changed over the years. And before I hand it over to Sarah to talk more specifically about school-based services, wanted to provide a little bit of information in terms of Medicaid eligibility coverage in particular, just to give you all, depending on your level of familiarity with the Medicaid program, some idea of the population that we're talking about. So from a high-level perspective, Wyoming Medicaid currently serves approximately 88,000 Wyomingites across the state. At any given time in the history of the Medicaid program in Wyoming, over half of those enrollees are children. We also administer the Children's Health Insurance Program, and right now there's approximately 8,000 children that are served statewide through that program. When we're talking about the children that are eligible and how those youth are eligible on our program, we're looking at income in particular. So the household income, as you can see in the slides we've prepared, under 200%. So we give the example of what is 200% of the federal poverty level. Just about $50,000 for a family of three. That changes based off of the size of the household, right? So if we're talking about household size of 4 or 5 or higher, that amount would increase. Specifically to the conversation here today, we operate a very targeted program that's called the Children's Mental Health Waiver that serves specifically children who are experiencing serious emotional disturbance. And from an income perspective, I mentioned that 200% of the family income level. For this program, we look at that differently. We are only looking at the income of the child, and that amount is about $2,100 a month. As you can imagine, there are not a lot of kids in Wyoming who have their own income over $2,100 a month. So essentially, income is very rarely a barrier when we're talking specifically about this children's mental health waiver through the Medicaid program. So what does that mean? What is the children's mental health waiver? So for any Medicaid enrolled children who are meeting the care management entity medical necessity criteria, they are going to qualify for some additional services. That includes high fidelity wraparound, that's care coordination, peer support, and respite, in addition to the Medicaid state plan benefits. And what we mean when we refer to the Medicaid state plan benefits would be the typical healthcare sort of coverage that all Wyoming Medicaid enrollees would receive, doctor's office visits, et cetera. So that's just a high-level overview in terms of eligibility. Yeah.
Okay. I'm going to ask a couple technical questions because the
Sure. Mr. Chairman, I don't have that date off the top of my mind. Would be happy to follow up with you. I know that program has been in effect for at least 10 to 15 years, if not longer than that. But that's a point we can take for the exact year to follow up on when that was authorized.
Okay, I can remember talk of a mental health waiver, and is that something different that we have not applied for?
Mr. Chairman, again, Stefan Johansson with the Health Department. We have, as you know, a variety of different waivers in the Medicaid space for folks with developmental and intellectual disabilities, home and community-based services for the elderly, this children's mental health waiver, which I believe was established in session law. I think it's around 12 or 13 years ago now, but we'll get back to you on that. There have been, Mr. Chairman, discussions about adult mental health waivers in the Medicaid program. I think with the work that's ongoing from House Bill 38 from a couple of years ago, the behavioral health redesign really allows us to answer questions that would be necessary with the feds if we wanted to implement and apply for another waiver in the mental health space with what populations the state is intending to serve, how we would pay for them, how we would target services geographically. But there's certainly a variety of Medicaid waiver opportunities out there. But the state of Wyoming has not gone in the adult mental health waiver space, just this small and targeted program for children.
Does the services here require parental consent to proceed?
Mr. Chairman, yes.
Okay. Anybody else have, I don't want to dominate, anybody else have questions on this one? Yes. Go ahead.
Thank you, Mr. Chairman. I did have one. So we have, for the eligibility, 200% of the federal poverty level as the basic eligibility for the family. It's my understanding that that's a selection by the state as to how extensive CHIP is in terms of the coverage, and that other states have taken that substantially higher to provide child health services. There are obviously a lot of other programs that the state pays for and support, and we talked about some of those informally earlier today with regard to using Medicaid to provide some health services through the school. Has an economic analysis been done at any point of what the implications, the financial implications would be of extending the eligibility of CHIP to a higher percentage of federal poverty level to see what the actual cost breakdown looks like across all of government? I mean, and I can't remember what the FMAP is on CHIP. I know it's at least 50%, but I don't know if it's calculated the same as the traditional FMAP. But has that analysis been done if we had the cutoff at 300%? I believe New York has a cutoff at 400%. You know, if those waivers and revisions were requested, what would that look like economically for the state? What would the cost be to the general fund? And would that be accounted for or offset by savings that we would realize elsewhere?
Mr. Chairman, Senator Rothfuss, we haven't recently done an analysis on CHIP expansion or extending that income limit. We certainly can. That work would not be all that difficult to do in my shop in terms of what that coverage would look like, what the cost would be, including what private insurance crowd out might look like from families that are on exchange coverage, for example, which is anybody over 138% of the poverty level. We could absolutely do that.
One follow-up on that. And actually on that point, these families are typically insured, many of them are insured families on the exchange. And yet CHIP is there for their kids, but not for the parents. And so you end up shifting, presumably, how that insurance looks. I assume that since it's a matter of selecting dependencies when you're going through the exchange, that is a relatively straightforward process. Are there any unintended consequences of that shift other than the fact that you end up probably taking some children off of the health insurance, the private health insurance programs that are purchased through the exchange? Anything else that should be considered there?
Mr. Chairman, Senator Rothfuss, very broadly, I would say it always depends on what type of coverage, public or private, the family has. So yes, there's a mountain of nuance in what type of plan a family would have and how that would change if Medicaid were there. We could certainly dig in, again, if the CHIP analysis is requested, or there's an interest in looking at what that expansion of coverage would look like, we can complete that.
Am I right in thinking that the 200% applies just to CHIP and not to Medicaid?
Mr. Chairman, yes. Medicaid, sorry for interrupting, Medicaid coverage varies by our categorical eligibility groups, but just for the committee's awareness, across Medicaid broadly, being low income does not qualify you for Wyoming Medicaid. You must, for example, be a low income caretaker, have be aged, blind, disabled, developmental disability, physical disability. So those income standards, Chairman Scott, as you know, change, but typically range anywhere from 50% of the federal poverty level to 150% of the poverty level. Children is a bit higher.
Okay. The CHIP program is now a Medicaid lookalike, is that?
Mr. Chairman, that's accurate. Based on legislation a couple of years ago, we brought the CHIP program in-house, operated by Medicaid, and it is a lookalike, but looks a little bit different than Medicaid state plan coverage for kids, given that the income thresholds are higher and a few of the federal rules are a bit different.
Okay. And committee, some of the history on what happened here was that initially the CHIP program was private insurance furnished through a Blue Cross provider. And they got harassed to the point that they were unwilling to continue. So we wound up with the situation we've got right now. Okay. Any further questions on this Medicaid? If not, let me ask one. I have heard that Wyoming Medicaid is paying for sex change operations on children. Is that true, and is this the mechanism?
Mr. Chairman, no, that wouldn't be accurate. And in general, Medicaid coverage requires medical necessity demonstration, both based on state and federal rule and law. That does get gray sometimes with what medical necessity is, but in general, Wyoming Medicaid does not pay for elective procedures of that type.
glad to hear that. Okay, anything else on this?
Mr. Chairman, if I may, this, for yourself and the members of the committee, this is not speak now or forever hold your peace on Medicaid. We've got about 4 more slides where we'll dive deeper
Let's go
into
ahead.
school-based services. So at the will of the committee, we're not done yet, but we'll do our best to keep it concise. At this point, I'll turn it over to my colleague, Sarah Rogers.
Thanks, Lee.
Thank you, Mr. Chairman. This first slide I'm going to go over is just going to provide a list of behavioral health services that are available through Medicaid for children. These include outpatient mental health and substance use services. So for example, that's services provided at a community mental health center, a substance abuse center, a physician's office, or behavioral health provider's practice or clinic. We have inpatient mental health and substance use services. An example of those services are just services provided at a general hospital, critical access hospital, a psychiatric hospital. We have applied behavior analysis, that's for children who have a diagnosis of autism. We have our care management entity and children's mental health waiver services that Lee just spoke about. We have specialty treatment for co-occurring conditions such as developmental disabilities and mental health. We have our psychiatric residential treatment facility services, which we have 2 located in state, and then pharmacy and medication-assisted therapy. And then also to add to this, Medicaid does not impose any cost sharing for mental health services, and Medicaid does not impose any cost sharing for services for any children. And now we'll get into the Medicaid school-based services. So the schools are allowed as a setting for treatment by Medicaid enrolled providers. And some examples of these enrollable providers are school psychologists, school social workers, school counselors, certified mental health workers, marriage and family therapists, and then our therapists, speech, occupational, and physical therapists and assistants, and then RNs, APRNs, and CNAs. Those are just some examples of who we can enroll as school-based service providers. In order for the services to be covered by Medicaid, they must be medically necessary and outlined in the student's IEP or IFSP and provided directly by the school district employees. So these services can be billed through Medicaid, to Medicaid, through the new school-based services program that we implemented on July 1st of 2022. So in those instances, a school district is the pay-to provider on that claim form, and then that employee of the school district providing the service is the treating or rendering provider on that claim form. This program enables the state to repurpose state and local funds to the school foundation program account and creates a potential cost savings to the state by claiming federal match on allowed services. In school year 2021 to 2022, there were approximately 7,000 Wyoming students who met the qualifications for Medicaid school-based services, or students that had an IEP or IFSP that were also Medicaid eligible. This next slide shows how the flow of funds and reimbursement occurs. So the care is delivered to the beneficiary or Medicaid eligible member in the school setting. The state pays for those allowable services when provided by, again, a Wyoming Medicaid enrolled provider. The districts are responsible for providing documentation of services delivered. Should that ever be requested in the event of an audit or something like that, they have to document the services that were provided. The claims will get electronically submitted to Wyoming Medicaid for reimbursement, and then Wyoming Medicaid will reimburse the school districts for services delivered, and the district will remit funds to the Department of Education School Foundation Program account. Next slide. So what more can be done for Medicaid school-based services? So currently we have 5 school districts enrolled as providers, and we have 1 district that is actively billing Medicaid. If more districts were to participate, there is a potential for increased funding, which could be used to help create a sustainable revenue stream for the School Foundation Trust account. In regards to telehealth, so should a district not be able to provide behavioral health or other medical services on site. The districts can serve as origination sites for that telehealth visit. So the provider on the other end of that telehealth visit, which may be in a different town in Wyoming, we would call them the spoke site, is what we call them in Medicaid, and they would bill Medicaid directly for those services provided via telehealth. Ongoing Medicaid enrollment assistance and events provided by the department and its contractors can maximize potential for school-based services billing. So we have a school-based services program manager back at Medicaid. He provides much one-on-one assistance to these providers, to these districts. He has regular calls, regular updates, creates newsletters. We can provide assistance with provider enrollment, with billing, just any issue that comes up. He and others work very close with these districts in regards to their billing and helping them with their Medicaid.
Okay.
Chairman,
Let me ask, are you finished with your?
I am, thank you.
so looking at, there's 5 districts that are participating. I believe we have 48 districts. So I'm wondering if you've had conversations about what needs to happen to maybe expand that, or what the gap is. I imagine there's probably more than 5 districts that have a larger population of students that would benefit from these programs. So just, how can we help kind of fill that gap? What needs to happen?
Yes, Mr. Chairman, Representative Provenza. There's been some, we do have only 5 districts. It has been a struggle getting other districts on board. What I've been told is it's just been a slow process. We're trying to work out the kinks with billing. It can be an administrative burden on some of our districts. But again, we're just really trying to provide any one-on-one administrative assistance we can to get them to come on board. It's just something we just continue to work on.
Which district is actually billing?
That would, Mr. Chairman, that would be Converse County.
Which of the Converse County 2
Mr. Chairman, you said there's 2 districts in Converse County?
Glenrock and Douglas.
Okay, I believe it's Douglas.
Send your office.
Thank you, Mr. Chairman. So one concern that I've heard raised with this approach, and I think it was 4 or 5 years ago that we really spent some time working on school-based service billing for Medicaid through the Education Committee and looking at which districts might be most appropriate. But when we have Medicaid billing, we have students that currently have services for mental health under CHIP, for example. And with school-based services not billing, they are getting service effectively in 2 places, and they have more comprehensive service available to them. The concern that I heard raised by mental health providers that provided mental health services to, our high school students, for example, was that policies under Medicaid basically have a number of visits per frequency that Medicaid would cover. Where many of those students through CHIP already reach that limit, and then they have additional support services provided to them through the school, and that was helpful. When we bill for everything, we eliminate the fact that there are additional services available because you've already reached your cap. I'm sorry, we can't see you now. And it's my understanding from the director that is policy, that we have the ability to be flexible on that. But it is a concern that was being realized, that's something that was raised by mental health providers as being something that would be detrimental potentially to mental health services. What can we do to address that? If we want to be billing more, I don't think it's our objective to provide less mental health services so that we can save through billing. I hope that's nobody's objective, but we obviously want to use federal funds where available. So what can we do to not realize that unintended consequence of diminishing mental health services by billing for school-based services?
Mr. Chairman, Senator Rothfuss, I believe you're referring to thresholds, and I do not believe there are thresholds applied in the school-based services setting. So you're talking about services outside of that setting. So if a client is receiving mental health services, let's say in the community and in school, any services that they're receiving at the school are not going to count against their threshold of 30 visits per year.
So when they're providing the school-based services, they are not billing to a name, so to speak? There is not an associated client that they're billing for? I would be surprised if that were the case.
Mr. Chairman, Senator Rothfuss, yes, there is. They are billing specific client information. Every client has a specific Medicaid member ID number. Each member also in our billing system has a threshold limit on their file. So our claims system will determine how many visits they've had. And since these claims are coming in by a school district, enrolled as a school district, under a school district taxonomy, the system's going to recognize those as school-based, and they won't go against their threshold.
Okay, so Mr. Chairman, to be clear then, that's already going to be delineated where the school-based service will not count towards the individual use, we'll say, of Medicaid service by that person with regard to the mental health provider.
Mr. Chairman, Senator, yes, that's correct.
And Mr. Chairman, if I can add to that, as we were discussing this morning off the record, those are not caps that are firm. Those are not, it's not 30 visits on the outpatient side. We're talking about community-based services now, not in the school. It's an administrative requirement to demonstrate from a physician or a provider that it's medically necessary to provide those. And you're absolutely right. Those are within, for the most part, within the administrative purview of the Department of Health. And can be adjusted. And as I said this morning, we will and can adjust those accordingly when determined appropriate. For example, when our prior authorizations reach very high approval rates, and it appears to be less of a service delivery issue or a appropriate service delivery issue and more now of just an administrative bureaucratic function where 99% of the prior authorizations are being approved, we will adjust those thresholds up or remove them altogether. I do think there is a balance to strike between, again, our responsibility with taxpayer dollars and paying for care that's most appropriate within our budget that's set by the legislature and the access to care. And we hope to strike that balance, but it's an ongoing process.
Let me explain a little further what I think is going on here. And I'm going to ask Medicaid to correct me if I'm wrong. There's a fair history here caused by the Campbell decisions, and specifically the provision in the Campbell decisions that we would 100% get state reimbursement at the school district level for special education. And since the Medicaid eligibility, most of the people with IEPs are Medicaid eligible. It's not entirely, what's the percentage?
Mr. Chairman, I don't know that off the top of my head. We'd have to do some digging. I would imagine it was significant. I don't know if it's universal.
Yeah, I think it's not universal, but there is a tremendous overlap. And for a while, in 49 other states, the Medicaid system for reimbursing for special ed is universal. And virtually all the other school districts in the country, I think, outside of Wyoming, Medicaid is paying a significant amount of the special ed expenses. With our Campbell decisions and our 100% reimbursement, for a while, Medicaid held that we were not eligible because they got a rule against supplanting state funds and our state funds were covering everything. We have found a way around that, which I don't pretend to understand, but there is a workaround. And now what's happened is the school districts have been unwilling to participate because Medicaid has significant paperwork requirements. And I can tell you from watching what goes on in child development centers, those paperwork burdens are significant. And the school district has said, why should we go through that when the state's going to reimburse for 100%? So we're asking school districts to do significant paperwork that they don't really have